Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we are exploring male infertility from causes to treatment options. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. The world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. Dr. Chandrika Parmar is an immensely experienced fertility specialist and gynaecologist, practicing fertility medicine and IVF in Melbourne for the last 2 decades. She operates from Epworth Freemasons Private Hospital in East Melbourne and performs clinical fertility services from Genea East Melbourne. Dr. Parmar, how common is male infertility and what are the common causes that GPs should be aware of?
So male infertility is quite common. About 50%, when you look at a male or female couple coming through, 50% is because of male infertility. And of the 50, I would say 30% is purely male factor, and there'll be 20% where it's not certain whether it's 100% male or female. So if you look at the dynamics of a heterosexual couple, 50% female, 50% male, and then there's a little bit of overlap between the two. In terms of your second question, what common factors? The interesting thing about male fertility is that there are lots of factors that can affect it. However, 60% of people, there is nothing found. And so no obvious cause, but poor sperm count. I think that's probably how we diagnose it. So it's a cause and effect both. So we would look at the semen analysis of patient and find that their sperm is not, either it's not enough quantity or quality or motility, or things are missing in the sperm parameters that are responsible for reproduction, for fertilization. So that's the most common way of diagnosing. As to why the sperm count is low, for a lot of people, the factors are not known. The GPs should, I usually say to most GPs that should start from the starting. If you're taking a history of a patient who's got issues with the semen analysis or is having problems with conception, and we think it's a male factor, you start from the starting. And start from the starting would be starting from childhood, just looking at, were there birth defects with their parents? Was there an issue with their birth? Were they premature? Were they born with some conditions that needed surgical correction? So some conditions like undescended testes are diagnosed when they're very young, and that might mean that they need to have surgery as a young child, and they might not be aware of it. Sometimes as they grow older, it may be issues with their reproductive endocrine system, and so the GPs need to be aware of some of those factors. And the interesting thing is all of this can be easily diagnosed either with blood test or with the history. So their testosterone levels might be down. They may not be producing the right hormones to get enough sperm production in the testes. There's often history of trauma to the testicle. They've had injuries as they were playing contact sports growing up. Very occasionally you have patients who are actually taking certain medication that may reduce their fertility, and they're not aware of it. They might be going to the gym and using some anabolic steroids to build up their muscle, and they think that makes them more manly, but however, that does affect their sperm count. And then there is lifestyle factors like smoking, alcohol, recreational drugs, sometimes inadvertently because they're using some medication to cure diseases which might affect their sperm count. So always a good idea to talk to the GP about all of those factors.
Why do you think male infertility is under-researched, and what can GPs do to ensure it is given equal attention in fertility assessments?
It's a really important topic, and I think there's a number of reasons why it is under research or under investigated. And part of it is that, historically, women think it's their business to have children, and because they carry the uterus and the eggs, and they get pregnant and they birth, they often are the first people to come forward and say, I'm having difficulty falling pregnant. Often man is seen as a person who provides the sperm, and if a man is ejaculating, then they think there is sperm. So an ejaculate is not necessarily equal to sperm. And often I think those social taboos, or the way the society perceives maleness might prevent some of the men to come forward and get investigated. I think there should be a lot more research, given that it's 50-50 equation almost. You would think that there would be more importance given to men in terms of investigation. And it's so simple to investigate. They just need a semen analysis to start with and perhaps some blood tests to diagnose. So I think it's a lot of education, the lack of awareness. And I think GPs are in a very good position to actually address that. I often see, when I see couples coming for, or anyone who requests an appointment, we always encourage their partner to come in. And often that means that we can simultaneously assess both of them, and that it's not just the woman's business, although eventually the woman falls pregnant, but well, it takes two to tango.
When assessing a couple's fertility, what specific tests or examinations should GPs consider for male patients?
Yeah, so very, very simply, a male patient comes and the simplest thing that they can do is a semen analysis. And a semen analysis is done by a number of laboratories. It doesn't have to be necessarily done in a specialized IVF lab or an andrology unit. It can be done by some of the very common pathology labs. I'm here in Melbourne. I would say the Melbourne Pathology, Dorothy Pathology, any of those pathology services close to home will have a collection center where a semen analysis can be done. A lot of these labs will be bulk billing patients, so there is no disadvantage of doing that initial sperm test. Obviously, when we find there is an issue with the sperm test, then we suggest doing it in a more specialized laboratory. But that can be done by the specialist if the GP thinks that they need to see a specialist. The other things that GPs can do is maybe a physical examination of the patient. If there is thought to be a history of injury, trauma, the patient thinks there's something not quite right with their genitalia, that can sort of indicate to the GPs that they might need an ultrasound. So a testicular ultrasound is quite easy to get as well. Most radiology services will offer that. And then some hormone studies, which includes doing their testosterone level, also their blood tests for their general reproductive endocrine hormones like the FSH, LH, testosterone, looking for their thyroid and prolactin issues, which can sometimes present as problems with their general endocrine system. And also if they have men who, have lifestyle factors, they might want to discuss with them those lifestyle factors to try and optimize health. Also in that would be an overweight patient who's diabetic or has some endocrine metabolic known factors, then they might want to optimize that. So these are just common things that they can do.
What lifestyle changes or treatments are available to improve sperm quality and quantity?
So in terms of lifestyle, I think the most important ones that we already know is smoking, and there is no safe limit of what smoking. And there's plenty of harmful effects of the smoking toxins. So I would say that perhaps cutting back on smoking altogether, usually going cold turkey. If they can't do that, then GPs can help them into a program that will slowly reduce their intake of nicotine. So smoking elimination, removing alcohol altogether, or perhaps limiting to less than 4 to 6 standard drinks in a week. If they're taking recreational drugs, we often tell them to stop taking those, whatever they are. If they're taking anabolic steroids for bodybuilding, they should stop taking those medication. And then if they're taking hair loss and some other medication that may affect their sperm, or if they can discuss with their GP what to do with these. The other factors, lifestyle-wise, would be excessive caffeine intake. There is, again, lots of studies done, but not necessarily a safe limit, but I would say 2 commercial caffeinated drinks per day would be probably where you cap it. And I think a lot of people would easily have 2 coffees and then several other caffeinated drinks throughout the day, like Coke and tea, which most people don't consider to be caffeinated, but they are actually. So I think keeping that down. There are a lot of these these lifestyle things actually cause problems with DNA damage to the sperm, and therefore minimizing that would be the best thing. There are some professions that might be at risk. For example, people who work in certain chemical industries and working with certain type of chemicals might affect their general health, but also affect the sperm production. So might need to sort of look at, well, that one is actually difficult when you're engaged in a profession that involves those things. You've got to think about changing your workplace, and that is often hard. So maybe from a, minimize that exposure if that's possible.
How can GPs support men who may be dealing with feelings of inadequacy or stigma around their fertility issues?
It's a very good question. Look, I think it is very, very important to men. I find roughly come into two categories. One that are quite scared to be diagnosed with a male factor abnormality, and then there are others that are accepting of it but don't know where to find help. So GPs can be the glue that helps them with all of these things. So there's lots of luckily, there is lots of information now available. The GPs can talk to them about, especially that it's a 50-50 question, and it's not that they're alone. There are lots of men out there who are actually struggling with male fertility. So one is awareness. Second is talking, validating their concerns. What are they, worried about, and how easily this can be treated. So there's lots of treatments available, and talk to them about reassuring them that this does not mean being diagnosed with any type of fertility does not mean that you have to have a childless life. And then again, it's the whole the old-fashioned narrative of a man and manhood, what they think that is, that needs to be discussed. So I think having a low sperm count does not make them any less of a man. I think those conversations are important to them. There's also lots of chat, online chat rooms. There's counseling support available. Sometimes you just need to be able to talk about things. And I think GPs can definitely refer them for some counseling. There's a lot of men's health forums available where they can express themselves and maybe connect with like people.
Are there specific cases when GPs should refer male patients to a specialist, such as a urologist, for further evaluation?
Yeah, so if fertility is a concern, then usually the GPs would refer the patient to a fertility specialist, and most fertility specialists will do a little bit of endocrine work. And so we do the reproductive endocrine part of the male patient. And then if there is specific conditions like they've done ultrasound and found some issues with their the testicular architecture, they've got some cyst, or they've got some blockage in the ejaculatory ducts, or there's been diagnosis of those sorts, or the patient's got history of not being able to, or the past history of having had surgery, a vasectomy reversal is required. And those procedures are often done by urologists, but there is an overlap between what services offered by a urologist versus what services offered by a reproductive specialist. So I think probably either or would be fine. There's another condition that can be diagnosed on ultrasound called varicocele. Again, varicocele can be treated by a urologist, or at least they can have a consultation about it, and often they can discuss with the urologist whether there is benefit to do surgery versus other modalities to treat.
What are some potential treatment options for men with low sperm count or poor sperm motility?
For low motility, we often, first of all, obviously, always start with the lifestyle, see if there's any corrective action we can take. Whenever we see a low sperm count or motility, whatever the reason that low sperm count has been reported, often recheck that. So 2 samples rather than one particular report. And sometimes we find that the second one is actually better than the first. But if it is true low motility, then there are treatments like antioxidants available. So they can have some, zinc, selenium, coenzyme Q10, just to sort of increase the motility a little bit. If the fertility is a big concern, then intrauterine insemination treatment, where the sperm is taken in the laboratory and sort of prepared in a way that it becomes more motile, and more potent amount of sperm is put into the female reproductive tract to try and help with the conception. And then if the motility is significantly low and it's really we're not able to overcome with just the intrauterine insemination, then would think about doing IVF treatment.
Are there reliable resources for GPs to refer men to for mental health support in dealing with infertility? And how can these services benefit male patients?
There's Men's Line Australia, which is one of the counselling online men's forum. There's, if they find the patient's severely depressed, there's obviously Beyond Blue. There's Lifeline. There's, say in Australia, people with mental health disorder. There's also sometimes, if they're single men, there's Dads with Distress. So there's a few things, a few places where they can be sent. I find that, and then the Andrology Australia, or this Andrology centres where there's usually counselling available. Men's Health has some counselling. For a lot of men, it is not just related to fertility, but maybe related to their general life and how they're feeling about themselves. So it may be interconnected to their generally feeling low and depressed about various things. It may be worthwhile just not to focus only on the sperm or the fertility side of things. Maybe overall would be good to have one-on-one counselling, because some men respond better to one-on-one counselling than group counselling sessions or chat forums. And I mean, a lot of it is also their attitude towards the whole, how does this affect the relationship? Because not to keep in mind, we don't want to encourage this, but sometimes it becomes a blame game kind of thing with couples when you're looking at them. It's his fault, but it never is. It's that 50-50 equation. When I see patients, I go, it actually isn't. It may be obvious on paper that there's a test result that's wrong for this person, but the other person's also affected. And because you're trying to create a family together, it plays into their dynamics, how they interact with each other. And, as a couple, they might just see, well, I see this as my letdown, I'm letting down my partner, or it may be that he's got other issues at work and he's got issues with erectile dysfunction or something else is going on, where I think the group sessions, don't really work. It's basically a couple session that works better, or a single person being able to express himself. And as, men and women work differently, a lot of female patients come forward and accept counseling quite easily versus men don't. And I think we've just got to not put them in a situation where they've been put to the test in front of 5 other men and they have to expose themselves. So I think more one-on-one counseling really helps some of them. Sometimes it's also, sexual dysfunction between couples, and you need to send them to a sexual counselor alongside, which I use all the time, because they often come back and say that we're just not able to connect with each other on an intimate level. So you've sort of got to, and that's what's happening in their head, is they're not connecting with each other. The flow-on effect is they're then sad and upset and miserable about the whole aspect of having a child or their relationship, and we want to sort of keep away from that. So if they're open to talking to their GPs, that's great, and often GPs are great in that way, that they've been seeing this person for a very long time, so they open up to them easily, and then working out what really is changing in the dynamics of that family or that couple, or is it a second child? Is it what is going on? Is there something with their general health? Is it to do with, a wider thing? So the holistic view of that person, and then going on and saying, okay, well, let's find you a right counseling service, or let's find you a right medium, whether that is, one-on-one counseling, is it group counseling, is it a sexual counseling, is it a couples counseling? What is it that they actually need to move forward? I do believe that a lot of men do relate to a lot of their GPs, and GPs are in such a good position to be able to manage this side of things. And sort of almost you want to normalize that this happens to a lot of men, and that it's not something unique to this person in front of you. They should be like any other person, any other condition. They should not be kept under quiet. I think it's easy, explore the opportunity of talking about fertility, what's going on, their general health. Very easy to diagnose, very easy to treat, very easy to move forward with it. So I think it's just having the conversation.
Thank you to my special guest, Dr. Chandrika Parmar. This podcast is sponsored by Genea Fertility. Genea has been helping create families for almost 4 decades. The world-leading IVF science and technology delivers success rates consistently higher than the national average, ensuring your patients have the best chance of a healthy baby. Referral and patient resources can be found at genea.com.au. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thanks so much for listening.